Hey, your microphone is not on.
How's that? Okay. No, thank you. Okay, so we're going to be looking at the paradigm shift and the treatment of obesity. We're going to try to understand what have the clinical trials with pharmacotherapy looked at when it comes to the component of nutrition, and understand when we're in the clinical practice with patients, what are we actually prescribing to the patients as healthcare providers based off of the science. And then we're going to just kind of summarize with really honing in on the hot topic question of where is nutrition going to fit moving forward. So let's jump right in. All right. So I want to give you all a broad overview of what it looks like on the current landscape of a comprehensive multidisciplinary treatment of obesity. Right now, you can see that there's a yellow arrow that's going bidirectional. And the reason for that is because we're offering all treatments at this time. It's not that you have to do one before you get the other. It shouldn't be a gatekeeping process. Similar to think about cancer treatment. If you know somebody who's gone through cancer, they're not going to get like a sprinkle of chemo or a sprinkle of radiation. Usually it's a very comprehensive, right, approach. We're going to have you maybe stop smoking because you have lung cancer. We're going to also have you get radiation, chemo, some surgery. So think about that framework, and that's what we're doing here in the obesity medicine space. But the question here is how much of a role does nutrition ultimately going to play as we're getting better and better tools to some of the other arms, right? So let's go ahead and talk about the paradigm shift that we're seeing and how we're approaching obesity. So you can see that even in the literature, we're talking about the changing perspectives and that we're really at an inflection point. We're moving beyond that simplistic approach that for years, the narrative in society and the narrative in healthcare systems has been that all you need to do is work out a little bit harder and eat a little bit less, and you're going to be able to lose the weight. And we know now that that's not true. We know that it's much more complex. This is a true, complex pathophysiology when it comes to obesity, and that we need to start changing that conversation. And so what we're seeing is a paradigm shift. We're seeing where we went from a comorbidity-centric paradigm. What I mean by that is that when you walked into the doctor's office or a healthcare provider's office and you would say, I have this ailment, whatever, let's say, your blood sugars looked elevated. They're going to talk to you about your diabetes, but they're not going to talk to you necessarily about your weight. It's going to be an afterthought. Versus we're trying to then move towards a weight-centric perspective. You come in the office, you have elevated blood sugars. Let's talk about your weight and how your weight is influencing those blood sugars, right? You see how that's changed. Now, there's pros and cons to that, but it's moving in the right direction is the positive there. Now let's talk about where we're really trying to get to, which is where we're in the middle of, and that's getting to a weight-inclusive approach. So let me describe what that means. So a weight-inclusive approach really means coming at it with a bias-free approach so that when that patient comes in, you're not blaming everything on the weight because not everything is due to obesity, right? But you are coming at it in a very non-stigmatizing way, and you are offering the services. At the same time, you're honoring that you need to promote healthy lifestyle, and that is going to be a key component. So that's where you kind of have this school of thought that I was talking with some of you all earlier today, some of the graduate students of, health at every size is this kind of conceptual idea of body positivity, acceptance at all body shapes and sizes, the idea that we could be metabolically healthy, but maybe at the same time with obesity. So the tricky part there is that we want to be able to give access to the tools that every patient may want to consider. We don't want to limit anybody having access to those. On the other end of the spectrum is weight-centric approach, which I was talking about was where we're kind of been moving towards, is having the conversation up front. Let's talk about obesity and the downstream effects on your health. And now we're finally getting to weight inclusive. So that's what I'll be referring to throughout the presentation, is that this is really the key that we want to get to. And that's because when we're talking about a weight inclusive approach, we're actually talking about obesity as a disease. Again, I think, hearing you all, and speaking with you today and last night, it's so wonderful to hear that the current thought, in this institution is that obesity is a true chronic disease. That's not necessarily true in every healthcare system. That's not true in our societal, norms. So understanding that there's over 200 medical conditions related to obesity, it's not due to a lack of willpower, and that this has been designated a disease since 2013. It really actually meets criteria for what we define a disease to be according to the AMA or American Medical Association. So it really actually checks off those marks, because one might be saying, why are you saying it's a disease versus, we would never question, let's say, cancer to be a disease or hypertension to be a disease. Well, we have outward signs and symptoms, and in this case, we're having increased adiposity, we're having increased morbidity and mortality, and then an impaired function of a tissue. And in this case, this is going to be adipocytes. So with that, we're also trying to see in the clinical realm that maybe we should be changing the name of obesity because there's so much stigma with it. Should we be changing it to something like ABCD, which has been proposed by some of our organizations, mainly in the endocrine space, thinking about calling it adipose-based chronic disease, because it would maybe lend itself in providers thinking of it more as a disease. As of right now, it's still hard for some to believe it that way. My point is that this is a complex medical condition. We should treat it that way, and that we should appreciate the pathophysiology of, adipocytes, looking at specifically, white adipocytes, and that they're a metabolically active organ, and that we know on a cellular level, and I'm going at this from a very high level, but just so that we're all on the same page, that this is really about sick fat, in that it's, having lipotoxicity or some type of inflammatory cascade. And there is really the exact mechanism that we're not fully understanding. And that's where we're looking to all of you who are doing the preclinical work to be understanding better at what are the precipitators that cause someone to go from living in, let's say, in an overweight state to a state of living with obesity. So as you can see, this is basically a cascade. And so I actually show this picture and have it printed out in the clinic for my patients, because I explain to them that when these adipocytes start to increase in size and proliferate and hypertrophy, this and the inflammatory markers are there, right? You see all this vascular genesis. It's very much like the horse is out of the gate. You're never going to be able to go back and turn around, even if you do the best diet and the best exercise. In most cases, there's always exceptions, but in most cases, you're going to need a multidisciplinary approach to help to bring this back into a normal state. And that's the hard part, because a lot of times patients have been trying and pounding their head against the wall, being like, I've tried every single diet. Why is it not working? I've tried every single exercise routine. Why is it not working? Well, we are not at the precision medicine state that we want to be at, and I can't prescribe you exactly what you need without getting a detailed history and trying to work from that. So we're still just really at the surface of understanding how to come at this in an individualized approach. So again, just talking about where this leads to is that, there's a lot of variables that come into play. And so going from healthy adipocytes to unhealthy adipocytes, we know that there's a lot of controllable variables and uncontrollable variables. And I talk about that again with the patients so that they understand that there are some things within their, control that we can try to work on, but there's also a lot of things that are not within their control. Endocrine disruptor chemicals, our environment, in that we're in an obesogenic environment, stress and genetics, et cetera. So you may be wondering or thinking about, well, are individuals who are living with obesity therefore going to be, persisting with this disease for life? And the research would say yes, that they're going to sustain obesity indefinitely, and that the biological pressures to restore their weight to the highest weight they've ever been at is going to persist long term. So how are we going to help these individuals to get their weight to a healthier place along with their metabolic factors? Well, that's the that's the million-dollar question, but it's coming at it again. And you can see I'm honing in on key concepts. It's this multidisciplinary, multimodal approach. And so patients are really never truly recovered from obesity. I often say to patients, because a lot of it comes down to being concerned about the stigma of having that on your medical chart, right? Like, I have obesity listed on my past medical history. And then when they are now, let's say, at a normal BMI, they want that removed. Well, if you had a history of breast cancer, and then you had chemoradiation surgery, lifestyle support, it improved, would we just erase that from your past medical history? We wouldn't. You would want to go to the ER if you had, I don't know, some issue, shortness of breath, and you would want to be able to let them know you have a history of breast cancer, right? You wouldn't just eliminate that. So similarly, individuals living with obesity who now are in remission are living with a history of obesity. And that's what we're seeing more and more that we're able to achieve, that we're having better and better therapies, such as the new pharmacological agents, which is what we're going to focus in on today, that I have the triangle on, that we're seeing so many changes in the medical weight management realm. And so there really is, just with these current medications, you can see how the evolution has sped up in recent years. And there's stars by semaglutide in that is in 2021 where we were able to really have this pivotal moment that we had something that was very, very efficacious compared to older generation anti-obesity medicines. But what I want you to take away from this slide is that older anti-obesity medications, first generation anti-obesity medications is how we refer to them, they've been around for a long time. They've been around since the 1950s. They just haven't gotten much traction because they aren't as efficacious as the newer ones. So the newer ones come in hot because we're getting 15% total body weight loss versus we're looking at older therapies, for example, monotherapy phentermine, that we're looking at somewhere around, 3 to 5% weight loss. So this is kind of just showing you the headlines in the New England Journal of Medicine article that came out in 2021 regarding semaglutide, and showing that this is kind of the evolution of the different randomized clinical trials for these medications. And these are the first generation ones where we're seeing, some of these medications are basically hitting, if you can appreciate, somewhere between 5 to 10% weight loss. And that is actually clinically effective weight loss. So when we talk about meaningful amounts of weight loss, of how much we're trying to help in terms of improving cardiometabolic factors, helping with quality of life, reducing mortality, et cetera, we're looking at 5 to 10%. And so that was a marker that we were able to hit. But again, there wasn't much interest and there still wasn't a cultural shift happening. This paradigm shift that we see happening as a society as a whole to visualize and perceive obesity differently is so critical to the adoption of healthcare institutions to implement weight management programs. And so these benefits, like I said, are profound, and we really can get health benefits from even a small amount of weight. And I want to quantify that for you just to appreciate that 5 to 10%, let's say if someone's living with 300 pounds, that's 15 to 30 pounds, right? So you don't have to necessarily lose 100 pounds clinically to be able to see improvements in blood pressure, hyperlipidemia, obstructive sleep apnea, et cetera. And the newer medications, so semaglutide and tirzepatide, what we're seeing is hitting numbers of 15 upward to 25% weight loss. So now you're 300 pounds and you're losing 25% of your weight in approximately 72 weeks in the study. So we're talking about a little bit over a year and a couple months. And that's a tremendous amount. So 75 pounds. So with that, you can see lifestyle interventions are modest, but also, like I've mentioned, critical. And then very low calorie diets or VLCDs, we've seen help with a little bit more weight loss, but those are not sustainable in the real world. And then what I'm talking about is like meal replacements. And then intensive behavioral therapy, we see a little bit more weight loss than just kind of general lifestyle intervention with 4 to 6%. But now we have the anti-obesity medications that when in combination with these lifestyle interventions are really getting these higher numbers. And it does more profound weight loss, equal greater improvement in health outcomes. The research would suggest yes. So where do the mechanisms of these medications? Well, we've been evolving in this space and now we're getting better understanding of the appetite regulation mechanisms and a better understanding really of the gut-brain microbiome axis. So that's been helpful in us trying to navigate where we're going with, targeting different areas of the body for pharmacotherapy. In this picture, you can appreciate that the newer medications, so semaglutide and then tirzepatide, are really hitting, we have a dual agonist with tirzepatide, and then we have a single agonist, which is the GLP-1 for semaglutide. And so we're hitting both the brain and the gut axis there, and then also there's numerous organs that have those receptors. So we're really getting some profound effects in that like I said, we're getting a better understanding of this signaling that I think is quite complex. You guys, I'm so excited to hear about all your research because it's always good to be able to partner with the preclinical folks to understand how we can bridge and create better collaborations. So with that, I just want to give you a sneak peek of where this is going. And you can see how many clinical trials are in place. The orange one is the one that's on the horizon, which John was kind of mentioning this morning, that term that's a difficult one to pronounce, the retatrutide. So retatrutide is our newest agent. That'll be the new kid on the block that you will probably be seeing in your media stream soon. And that one is going to be hitting upward of 25% for patients. So stay tuned. So let's go into now the role of nutrition in obesity pharmacotherapy clinical trials, because we need to understand what role has nutrition played in conjunction with anti-obesity medications in order for us to understand where we're going. So the main seminal trial that really looked at this was sibutramine, which was by Wadden et al. In 2001, that his team looked at this and was able to appreciate that looking at sibutramine, which is a first generation, really, really old school anti-obesity medication in combination with lifestyle instruction, which was very basic. It was very minimal. So it was looking at 1,200 to 1,500 calories per day, plus exercise 4 to 5 times a week for 30 minutes is what they were instructed to do. That was the extent of it, plus a little booklet. And the booklet was to support them to do their lifestyle. So minimal support plus medication. Then you had sibutramine plus behavior modification, which was about 20 weekly group lifestyle modification sessions. And that was also instructing similarly about diet and exercise, but it asked also that these participants do daily tracking. And then finally, there's sibutramine with behavior modification and meal replacements. And the meal replacements was extremely, difficult. This is 1,000 calories per day, 16 weeks where they were doing 3 meal replacements with a balanced frozen meal in the evening. And then they eventually went back to conventional foods with 1,200 to 1,500 calories per day. So you can appreciate from this slide that the weight loss or total body weight loss achieved, you can see how much it improves with the addition of lifestyle in combination with the medication that we're going from 4, 10, and then 16%. So it really gives it a boost. And examining really this added effect of intensive behavioral therapy in pharmacotherapy trials, you can see the evolution in that I want to focus on this slide, the placebo plus minimal support and the placebo plus intensive behavioral therapy. So that would be looking at these kind of pink and yellow bars. And you can appreciate here that, let's say for some of these older agents, going with just adding in this intensive behavioral therapy, that they're really not getting any drug therapy, you can see that they're making very, very modest weight loss. Then we are looking at the yellow being the placebo and IBT, and that's a little bit more. But then what I want to point out is looking at now the drug with the minimal lifestyle support versus drug and intensive behavioral therapy. And what you can appreciate here is that you can see the change, that it's much bigger in the earlier part of the slide with sibutramine, naltrexone, bupropion, liraglutide, that you're getting more bang for your buck with the added lifestyle arm versus the newer medications. Let's look at semaglutide, 15 to 16% with adding in IBT. So that's the hard part, is that we're not seeing as much of a oomph or as much of a boost when we're adding in the lifestyle arm in these newer medications. And so the question is, why? What's happening there? So I'm going to focus in to try to kind of look at this and examine it a little bit more. So let's start with liraglutide. Liraglutide is one of our older GLP-1s, or older second generation medications. And this one is basically looking at a multi-center study, and that's the SCALE study. And then we're looking at a liraglutide plus intensive behavioral therapy study, which was a single site open label randomized trial. And so what I want you to see here is the comparison of minimal support plus placebo and drug and minimal support. And then I want to look over here and look at placebo and IBT and drug and IBT, and then drug, IBT, and meal replacement. So the keys here, though, is to appreciate that the participants in all of these 3 groups received the same type of intensive behavioral therapy. So you can see the description here, and I'm not going to go into it in detail. But I wanted you just to appreciate that this is similar to what we get reimbursed for Medicare, and that it's basically numerous sessions that you're getting. That's about 15 minutes of intensive behavioral therapy counseling with patients. And then in combination with that is doing, besides the instruction, they're also having participants follow up with medical visits over the year. So the goal here is really to understand that this is, with this patients being able to be on the medication plus the intensive behavioral therapy support, you can see the jump from 6.1 to 11.8, 11.5. Here with the minimal support and placebo and drug, you can see what the drug is doing. So the drug here is giving you about 6% gain. Here you're getting also about 6% gain from the intensive lifestyle therapy. So you're seeing a true tremendous effect of the combination of these two arms of treatment, lifestyle and medication. Now I want to compare what you're seeing here with older GLP-1 liraglutide, now with newer GLPs. Like now we're seeing, let's look at lira and tirzepatide. So this is a weight maintenance trial. What I want to kind of demonstrate here is that in liraglutide, they had more counseling sessions. They had 17 counseling sessions. Tirzepatide, they didn't need as much counseling sessions to gain bang for their buck to be able to achieve higher percentage of weight loss and have cardiometabolic outcomes that were positive. So you can see that only 6 counseling visits, they were able to achieve nearly 25% weight loss. Here with liraglutide, they had 17 counseling visits and they only achieved 11%. Now, yes, tirzepatide is more efficacious, is a dual agonist. So that's the point, is that we're moving into an era where the medications are so good. Do we really need to still have that much counseling? What type of counseling? By whom? What is the composition of the diet that is affecting it? We don't have any of these actually answered, but I'm showing you what we know so far to help to encourage you and prompt thoughts about where we can go. The other part to this is about non-responders. So a lot of times in my clinic, I see patients who do not respond to the medications, which you can imagine is very frustrating considering that all of social media is like glamming over that they're doing amazing and dropping hundreds of pounds. So what do we do with patients who are non-responders to the medication? Well, think about that kind of colored picture I showed you in that we go to other treatment modalities and try to see what we can combine. And so we start getting creative with what exercise plan we can do, what diet plan we can do. And the precision we can do with that is only so much, right? In the clinical setting, we can't, we're not advanced enough to be able to say, okay, we're going to be able to know exactly what exercise works for you, like John was saying earlier. It's really trying to come up with an individualized approach based off of their history. Oh, you used to swim when you were in high school and you were able to do really well with, enjoying that activity and you want to get back into that. Okay, so that's feasible because you can do that. Or, oh, a couple of years ago, you were really great at walking and that worked for you in combination with doing a low carb diet. Okay, so it's finding out what's worked for them in the past and what hasn't worked and trying those again. That's really where we're at in the clinical space. But what we see is that when patients are not responding and losing the minimal amount of what's clinically meaningful weight loss, meaning at least 5%, you can see here with liraglutide that 11% of patients did not lose the minimum that we would want. Versus the newer drug, tirzepatide, 17.5% did not lose. So that's interesting. The newer drug that's more efficacious, more people did not lose the minimum we would hope for. Why? Well, one could argue and interpret from that, okay, maybe it's because they didn't have the other arms of treatment to fall back on. They only had 6 counseling visits. So that's kind of where we're speculating it there. And then the last is I want to go over, see if this one will come up, is to look at the comparison of intensive behavioral therapy plus anti-obesity medicine trials with just the newer medications, so semaglutide and tirzepatide. And you can see that with semaglutide, they actually included 30 counseling visits over the course of, it's about a year and 4 months. And then with SURMOUNT-3, which is tirzepatide, again, they were sticking with the 6 counseling visits. Ultimately, tirzepatide leads to greater weight loss. And so my point here is just that we have so much variability in how we're delivering the intensive behavioral therapy arm, which includes the nutrition, that it's very tricky right now at this stage to know how much nutrition counseling is needed. And we don't have any data in terms of what these medications plus the ideal nutrition composition should be. So it's a wide open field. Also, the delivery of this information is another piece to this, and that's where I wanted to bring in this study that was done by the Academy that was looking at it was a systematic review, honestly, reviewing all of the 62 randomized control trials that were trying to understand in adults with overweight or obesity, what is the effect of weight management interventions provided by an RD or an international equivalent compared to usual care or no intervention. And what they found was that the delivery by an RD or an international equivalent was statistically significant for improvements with BMI, with waist circumference, with percent weight loss. And so the takeaways was that it needed a lot of touch points, and that meaning that they needed to be seen by a provider regularly, that they were seen for over at least a year and had follow-up at 3 years. But again, this is another point of a variable that we don't fully understand. Could the delivery have been by an exercise physiologist and an RD? We don't have that information. So now I want to tell you, based off the fact that we're just scratching the surface of this field, as you can say that I'm telling you that there's a lot of questions to be answered, is what are we telling our patients then? And I want to go over that with you. So right now, the nutrition recommendations that we tell patients is really that nutrition is the foundation for overall health. We know that well established in the data, and that we also want to help to optimize metabolic improvements through personalized nutrition interventions, that not one size fits all, similar to what we talked about this morning with John for exercise. And then when it comes to these anti-obesity medications, there's a new space for the role of nutrition, actually, that is critical, in that there are side effects with these medications that we have to be able to mitigate. There are also, challenges with potentially nutrition deficiencies. And we see now combination therapy where we're having patients with bariatric surgery and also having had a gastric balloon, which is some of the new bariatric endoscopic procedures, and they also are on a medication. So how do you manage all that with a nutrition plan? So that's where we're having to kind of bring it into a new space when I mentioned that nutrition is having a new role. So the clinical effects of improved diet on weight management we know are numerous. We have reduced weight, reduced visceral obesity, we have reduced health complication, improved sleep, and increased life expectancy. And we know that most people with obesity, have tried lifestyle modifications oftentimes when they're coming to see us in the clinic, and that many of these individuals are ultimately going to need some pharmacological agent in combination with lifestyle. With that, looking at the guidelines when it comes to pharmacological management of obesity, all of them are in sync in recommending that diet, exercise, and behavioral modification be part of all obesity management approaches. Great, very generic. So all of y'all who are out there, who are super deep into the research preclinical and have this beautiful study question I heard about from several of you today that is very focused. This is where the land is for the clinical space. So we're very broad, and that often means that people are getting varied counseling, which is troubling, because it makes it hard then for patients to be able to navigate those waters themselves, because they're getting a lot of different information from potentially healthcare, from media, from family, friends, et cetera, and what they read. So now with dietary recommendations for patients living with obesity, what we've tried to do at Cedars in working with my RDs, what we've tried to do is really come up with general healthy principles, because thinking about family members or friends or yourself or whatever, everybody tries to come up with this perfect diet and say that this is the diet that's going to work, right? And that is not the case. And so what we've been trying to do is reteach patients to think about this as more of principles, of healthy principles that we know from the literature that are going to be helpful, often many of which are based off of the Mediterranean diet, but ultimately these are generally healthy principles that can apply to majority of patients. And as a result, we then individualize it based off of these healthy principles. So, the research supports showing here, that we have studies from over a decade ago showing that weight loss over 2 years in adults assigned to one of 4 diets with kind of different proponents for the macronutrient composition, that ultimately the weight loss was fairly comparable. There was very little difference in this. So what is the takeaway here? It's that, one size doesn't fit all, that you need to be able to appreciate that, some people are going to be responders to a low carb, some people are going to be responders to a low fat. We as clinicians rely on the history to be able to guide us to say, okay, that worked for you in the past, now let's try to apply it again. And so we can't come in with a cookie cutter approach. And so what we're hoping is that more and more from the research you all are doing, and that we can work with you on, we can better understand how to do precision medicine. So, oh, I don't know what that is. Oh, let's see. Sorry about that. So some of the components of healthy, intense, in comprehensive lifestyle interventions for weight loss, these are some of the kind of overviews that we do. So we talk about trying to do with patients typically, a combination of diet, physical activity, behavioral therapy, and then also talking about how frequently we see them. This is based off of the concept of intensive behavioral therapy. And so with that intensive behavioral therapy, we, are looking at potentially, this is what ultimately kind of Medicare reimburses is 14 visits, sessions in 6 months with a trained interventionalist. And again, that goes back to the concept of who is, best positioned to be able to do that and what will be the most effective for patients. See how I'm doing on time. Okay, interest of time, I'm gonna kind of speed forward. So I'm just gonna speed forward through these. Okay, so I wanna go over kind of the mitigation and treatment of medication side effects because this is a big kind of, this has been, I would say, to a degree hyped in the media in the sense that there are side effects with these medications, 100%, that's true. At the same time, we know that for severe side effects, this is gonna be less than, about 7% of patients. And so really what's key is, I know there was a question earlier today that was asking a little bit about dosing. Key is about how we are dosing the medication to be very, very judicious with that. And then also with trying to help in navigating it with diet, to be honest, because diet can serve so much in the prevention of some of these side effects and then also treatment. So we really try to optimize protein intake, ensure adequate hydration, because a lot of these patients are at risk for dehydration because not only is it turning off signaling in terms of reducing, I should say, the signaling of appetite, but also the signals for thirst. So these individuals are finding that in the clinical setting, we're having to like remind them about water intake. And so it's a shift in the way that we're honestly practicing because before we were having to focus on calorie reduction and on just trying to help individuals eat less. Now the medication is serving so much of that purpose, we're not necessarily having to go down that route. We're able to really focus in on other aspects of the lifestyle counseling. So with that, we have eating behaviors that we really try to talk about with the patients in terms of eating slowly, trying to avoid distractions. And then with these patients, oftentimes one of the side effects is acid reflux. And so we try to have them also practice good habits to reduce GERD, which means avoiding laying down after eating a meal. And so limiting fats is also one of the key components that we counsel them on because a lot of times they can experience GI side effects like nausea or potentially even diarrhea, constipation, vomiting. And so we try to limit fats for their diet if possible. Again, it's personalized nutrition that we're aiming for. So we try to encourage them to do the best meal plan that's going to work for them. But if they're having GI side effects, then we may need to consider limiting fats. All right, so I want to review where nutrition will fit in the evolving obesity treatment landscape to really kind of hone in on the question that you all were asking earlier in that this is kind of the bread and butter of what today's or day is talking about. So when I was showing you this kind of treatment landscape that we have and that there is a continuum, the important part to know is that nutrition isn't going anywhere. Ultimately, nutrition, exercise, and healthy behaviors is going to be the foundation and remain the foundation. And whenever we're prescribing and using medication therapy for obesity, it's always in conjunction with healthy lifestyle. You've seen that today in the trials that we looked at back with the older medications to the newer medications. So the effects of these medications are really gaining a boost from lifestyle, but we're not seeing maybe as much of a boost because the medications are so efficacious. But does that then mean that nutrition doesn't have a role? No. It just means that it has potentially a different role, like I'm mentioning with vitamin deficiencies or addressing, mitigation of side effects. And also, of course, it's going to be the foundation because it's just important for having a healthy human body. So I want to say that it's here to stay. And then I also want to just mention that with precision nutrition, understanding the complex interrelationship of numerous variables is where we're trying to go towards with precision nutrition and ultimately to facilitate precision medicine. And so we want to optimize metabolic responses to diet. We want to be able to tailor dietary approaches. And we want to make sure to be able to make sustainable and targeted individual dietary recommendations to prevent disease, treat disease, and also be able to improve overall health and well-being. And so I really like this image that's actually from a working group paper and that Elizabeth had worked on. So application of precision nutrition, this is about some of the special populations, and this is referring to what I want you to think about in terms of the research space, and then also thinking about kind of what we're seeing in the clinical space, because these are the populations that it's very, very understudied. How are we going to be able to apply precision nutrition in conjunction with anti-obesity medicines, in conjunction with bariatric surgery to optimize the health of these individuals? So we have individuals that we see who are living with sarcopenic obesity or disordered eating. And oftentimes, these individuals, although we know that dietary factors, for example, there's studies that show that dietary factors such as like diet quality and the intake of certain calories and protein and fruits and veggies can affect or be linked to sarcopenic obesity. We don't necessarily have that type of, and that's just preliminary data, but we don't have that data when it comes to other aspects of complex diseases that we're seeing. For example, cirrhosis or end-stage renal disease. What is the best nutritional composition of a meals that an individual should be having in order to facilitate weight loss, maintain that weight loss, and improve metabolic outcomes for their liver health? We don't know the answers to those questions yet. And therefore, I'm already telling you about some of the questions that remain, and this is to get the wheels turning for you to think about the translational aspect of much of the work that you all do. And I think one of the parts I want to highlight from the studies I've showed you today is that there's a lot of gaps when it comes to especially ethnic, racial, and gender differences that we need to really try to work on. John was talking about earlier today that understanding body comp, understanding that lean muscle isn't the same as whole muscle. We don't have that type of data again with anti-obesity medications. So I know I'm telling you a lot of things about what we don't have, and I'm hoping that's sparking questions in your mind that you want to answer, be it preclinical or clinical, because we need help to advance the field. The exciting part is that we're having this conversation because had we not had these medications that I've shown you today, these newer ones that came out, specifically semaglutide in 2021, we wouldn't really be in this space right now. It's really accelerated the field to be having such effective medications. And not only are they helping individuals to lose weight, as we talked about earlier today, it's not the goal of just losing weight. It's the goal of improving health outcomes. It's helping quality of life, functionality, and ultimately just reducing mortality. So giving these people a chance to live longer. And so with that, I want the takeaway points that I'll summarize, and then I'll leave about 15 minutes or so for questions. A paradigm shift is occurring in the treatment of obesity and is underway with the rise of more effective anti-obesity medications. We know that losing weight and maintaining weight loss is very, very challenging. It's all about, people often having this narrative that is not correct, in that it's just eat less and move more. We know that it's actually more involved than that, and it requires us to be able to come at it with a multidisciplinary approach. The research has demonstrated in clinical trials that anti-obesity medications in combination with intensive behavioral therapy lead to improved health outcomes. And so we know that it's always that combination that we've been looking at. And in clinical practice, when we're talking about nutrition, we know that the role of nutrition is there and it's there to stay. It's just kind of answering the questions of what, when, and how. So what, when, and how, like what should someone be eating? How should they be eating it? What times should they be eating it throughout the day? We don't have that kind of answer yet. And then also understanding about the nutrition counseling component. Who's it delivered by? How long is it delivered by? Are we doing telehealth? Are we doing, in-person visits? Is it group? So it's really exciting to be in the clinical space, experimenting with these different approaches to be able to optimize the care that we can provide patients. And it's also very exciting that patients or individuals in the society are now interested in walking in the door, because so many weren't even aware that these treatments existed. And now we actually have an opportunity to be able to care for more people because of such an increased awareness. I mean, be it a double-edged sword with the media kind of, broadcasting lots of things regarding, the hotspot of these anti-obesity medications. With it, the positives, I would say, is that more awareness has brought more individuals to receive care. So I will conclude with that's my contact info if anybody needs anything or wants to chat. And I'll go ahead and wrap up and then answer any questions you have. Yeah, those are good questions. So I'll start with the first one. So I think it's a combination of both. I think that the accountability that comes with the visits is key, but the other aspect to it is the counseling. And so I do think that it's going to be both that is driving it. When it comes to tools that we're making, that they're having available in the clinic space for us to help patients to have the accountability and to deliver the lifestyle counseling, because as you can imagine, and you're probably experienced with the pandemic and then getting back into getting your own healthcare services or seeing loved ones trying to get it, it's hard, right? It's super hard. And so with that, we do have some tools that are being leveraged. And I think that those tools, the hard part is that they're not always evidence-based. And so that, the beauties of AI, virtual medicine, and technology with all of us having, cell phones at this point being ubiquitous is where I would hope to see something come into that space. But the challenge is that when these programs are being developed, some of the apps that are out there, they're not being able to individualize the approach. They're giving a cookie cutter approach, and maybe it's allowing for a touch point, which is then delivering that arm of accountability, but it's not giving an individualized approach, which then ends up being defeating for the patient potentially who's not able to respond to it. And so that's where you can see, like, I'm thinking like we could talk about any of the programs, Noom, Weight Watchers, these are a lot of these structured weight loss programs that as clinicians, we try to rely on because we may not have the staff to be able to support lifestyle visits at that frequency that we're seeing is efficacious in these studies, right? Is it really realistic for me to have, 14 clinical visits with these individuals? No. So that's the trouble that we're encountering. Mm-hmm. Thanks. Yeah, so at this time there isn't. But right now what we're seeing is that individuals are being able to maintain at 5 years out with these medications and maintain their weight loss if they stay on the medication. And then of course we're seeing, and John showed one slide and I didn't show that today, but we have clinical trials looking at these medications that if they stop the medication after being on it for 1 year and look at it at year 2, so basically months 13 through 24, what happens? And if they're not on the medication and they're only following lifestyle, they will have regain of 2/3 of the weight. So that's quite profound, despite trying to keep up with the lifestyle. So the key here is that, yes, we're seeing that at least for 2 to 5 years in the studies, respectively. We know that individuals can maintain their weight on these, but the hard part is access to the medication, cost of the medication, and being able to stay on it then. Mm-hmm. Yeah, good question. I know that one I keep on there to create awareness, but it also, without much explanation, it could be hard to appreciate what that means. So I'm glad you asked that. So body contouring is not very common. It's usually for individuals with severe obesity, meaning individuals who have been living with obesity of a BMI of 50 or higher. So we're talking usually with individuals who have at least 100 pounds excess adipose. And as a result, those individuals will often end up with potentially loose skin or what we describe in medicine as a pannus, which is an overhang of tissue over their abdomen. That can actually be very debilitating and cause a lot of medical complications. Candida or yeast infections under the skin fold. It can also be very difficult for mobility purposes. So, you know, we were having a great discussion at dinner last night, talking just about like the ability and kind of individuals living with obesity to be able to have the movement that they want to move like, and it can be very hard for them. As a result, that's where plastic surgery, body contouring comes in. So don't think of it as a cosmetic aspect. This is about true functionality. One of the cases that comes to mind that was incredible was that two colleagues who I do a lot of education in the healthcare space to teach other professionals that they should be treating obesity. So plastic surgeons who don't want to see, let's say, obesity as a disease may never offer someone with a pannus to do that surgery because they think that they should go do diet and exercise, right? So in two colleagues who I helped to really get them to appreciate that obesity was a disease actually did surgery on a patient who came in with a complaint to a urologist. My colleague's a urologist, and she was unable to do a visual exam for the urological issue because of the degree of pannus hanging over, because he had lost over 100 pounds with bariatric surgery and lifestyle. So two medical arms of this picture. So as a result, she asked plastic surgery to do the surgery at the same time. And he actually had some issues with his prostate that she had to take care of. And so she did that surgery while they removed the pannus. So life-changing. So that's where that comes into. Do we know for those individuals who have a greater degree of skin and and some degree of adipose tissue remaining in that area after such profound weight loss, what are the metabolic effects of that? No. Very difficult. Yes. Yeah, so that it's partly so part of it will be about trying to show the medical reasoning behind it. So it often requires then so much legwork on the physician's end, which is hard in today's world where we have so many patients. At the same time, insurances are trying to again not recognize that having skin removal from excess skin on the arms or the inner thigh or the abdomen that often results after profound weight loss is medically necessary because they don't see obesity as a disease. So why would that? Yeah, exactly. So it's a challenge. You're right. That's exactly where the pharmaceutical companies are at in positions right now, which is hard because they're trying to, make up for all the costs that they've spent doing the research to be able to get this medication. And I see their perspective, but I'm more concerned about getting it accessible to the patient. And we won't probably see movement with the pricing until there's more competition. And that's just a sad reality. And then also when they're having to go to generic. So that's years, to be honest. In the meantime, how do we get it to patients, especially our patients who are Black and brown, who are in historically underserved communities? How do these individuals get access to these medications? It's honestly going to be through providers trying to advocate for those patients to get that access, provider education, and then also having support to be able to facilitate approvals for insurance. I was talking about this with clinical colleagues earlier today, pointed to Jen, in that we were talking about the hardships of payers or insurance companies not wanting, basically moving the bar for what they will allow for coverage. So they're saying, oh, we used to cover these medications for all BMIs. Now you have to have a BMI of 40, then we'll cover the medicine. Or, oh, you only have one comorbidity. You actually have to have two. So they're just moving the bar to make it harder. And that's where there's so much strife, because for patients, and you can think about yourself or a loved one, when you walk into the clinic, you ultimately, the appearance is that we're the gatekeeper, us as the provider, we're the gatekeeper, and we're not the ones that are holding that back. We want that medication in your hand. But the hard part is going to be that competition's needed, time is needed, and not everyone is going to get access to it right now, but we need to keep advocating, and policy change, ultimately, health policy change, if anybody is into that. Yeah. Yeah, those are good questions. So I'm going to start with the first one. So your question is, with the medication, I already forgot the first question. Oh yeah, why would, yeah, okay. So the reason is, I know it's gonna sound funny, but I'm gonna come back with your question with a question. So if someone came in, and John was saying something similar this morning, like if someone came in with having a recent heart attack, right, would you be like, okay, you know what, let's start with no smoking and a little bit of diet exercise, and then we'll think about a baby aspirin. You know what I mean? And also, it's a little bit of a bias from, I think, media in us getting this perspective that like people are like, vomiting profusely in the corner, or like that's the reason that people are losing weight. That is not the reason people are losing weight. The people if you have loved ones, if you yourself, if anybody you know is experiencing that, that's not right. That's not what we're aiming for. What we're aiming for, these medications are not special, to be honest. Like they're incredibly effective, but I want you to think of them as, and you may have people in your life who are on a statin or on a blood pressure medication. These are just run-of-the-mill meds, honestly. They're very good. They have cardiovascular benefits. We're seeing now that they have potentially effects on the memory that are improving. Also, they help with weight loss. They have blood sugar improvement, insulin resistance. So yeah, they do a lot of good things. And they have side effects. All medicines have side effects. Those commercials that come out on any of the pills that you see, like, and don't forget, you can die. Yeah, so these honestly, the severe side effects with these, like pancreatitis, again, I'm just going to tell you things I know are in the media, like pancreatitis, gallstones, those are less than 1% of patients per the research. So not a big number, right? Yes, you have now thousands of people prescribed it. There's going to be a couple TikTok videos of people having that issue. But it's like I said, it's getting overhyped. All drugs have side effects. Second question. I already forgot. Yep. So we don't have good research for knowing if they potentially could get off of it. The research showing right now is they need to be on it for life. Similarly, think about it for a blood pressure pill. I mean, ideally, I don't want someone to have to be on a blood pressure pill for life. And the beauty of these medications, I want to point this out clinically, if you haven't kind of thought about this, is if a patient comes into me, usually if they have potentially obesity, they have a little bit of high blood pressure, a little bit of prediabetes, right? A little bit of everything. The beauty is us as a provider, it's so rewarding to take them off of medicine. So I say to them, what if I could give you one medicine, a GLP-1, semaglutide? I could put you on that, and I could peel off 2 of your blood pressure pills. I could also help you to be able to walk a little bit more because your knee pain's improved and you don't have to take ibuprofen 4 times a week, right? So to me, my goal is, could I give you one and take away others? My goal isn't just to pile on everything, but that's the paradigm we've been in. When I started that first slide with the chronic disease management, that's how I was trained. They come in with hyperlipidemia, statin. They come in with knee pain, aspirin, ibuprofen, Tylenol, ice, and PT. So now instead of just throwing everything at them, what if we step back, treat the obesity with one medicine plus surgery, and reduce all that burden? Mm-hmm. Yeah, you're right. So there's no, like, who really needs it versus who needs it is subjective at this point. And then one could argue it's due to the burden of medical conditions, right? This person has 30 medical problems, this person has two, and that one potentially needs it more. So how to define that, I think, is hard, A. B, when we're looking at the medication and saying, okay, I'm not going to use it per the drug insert, and the drug insert says this is indicated for type 2 diabetes. Again, this is something kind of that's gotten, I think, a little overhyped in the media. And then they're taking it away from the type 2 diabetes, individuals and taking it for patients for obesity. It is not good for individuals, like individuals who are living with diabetes and not getting these medicines is medically inappropriate. At the same time, people who are taking the medication who are not indicated to have the medication, they want to lose 5 pounds. They want to go to a party or prepare for, I don't know, something, right? That's medically inappropriate. So those individuals taking the medication off label is inappropriate, and we don't practice. That's not how we practice, or we shouldn't be practicing. We were just talking about, yes, I'm pointing to Alexa, was mentioning in Grace that we have, even here, Nowhere's Immune. I was saying it was also in LA. They're like the minute clinics, right? That the people promoting, like, get GLP-1, for $300 a month and pop in for a vitamin B12 injection. My point is, that's not medically appropriate. It's creating noise that we shouldn't be paying attention to. And no one has a little like blood pressure clinic that's like, get some like, losartan for your blood pressure, right? Like, not exciting. No one wants that. So it's a weird phenomenon because I'm having people come to me wanting to have medicine, wanting surgery. Who wants to have your heart valve replaced and be on aspirin? No one. So it's a very different thought process. My point is that's not good. That's not appropriate medicine. And for individuals who are getting the medication with obesity who need it, but maybe don't have type 2 diabetes and they're getting prescribed, let's say, Ozempic, that is a common practice in medicine that like has gotten zoomed in on because of a different lens that we give obesity. Because they're like, do they really deserve it? Yes, they deserve it. It's a true disease. It's not about deserving it. It's about everyone should have access to these tools. We do off-label prescribing in medicine all the time. So when you take Tylenol for, I don't know, a headache, it's actually the drug insert, is for pain. Headache, pain would be defined as like having knee pain, right? Not a headache. So we use drugs off label all the time. They've just kind of, again, hyper focused on like, how dare you give it to these individuals and not those individuals? And my point is, there is a group who shouldn't be receiving it. But when we're giving it to someone who has obesity and needs a transplant and has cirrhosis, but they don't have type 2 diabetes, and I can only get Ozempic covered, I'm going to order it. Yeah.